The topic of this video is auditory evoked potentials. These two potentials, Ecog and Abr, are called early responses because the response that we measure and observe electrophysiologically starts soon after the stimulus that we're giving is presented. Before we begin, we need to just review the cochlear potentials that were discussed in hearing science. I know that some of you have had a little bit longer time between when you've had hearing science and now, and some of you had it last semester. So, to look at these potentials is important because we'll be talking about these potentials, and all of these potentials are cochlear potentials, and these potentials are responsible for converting the hydromechanical energy that flows through the cochlea to electrical energy so that it is able to be recognized by the brain. So this conversion process happens in the cochlea to the first to second way station along the central auditory nervous system. The first potential is a resting potential called the endocochlear potential. Sometimes you'll see it referred to as the EC for endocochlear. So the endocochlear potential occurs even when there's not a stimulus, and it's essential for hearing. The endocochlear potential comes from the flow of potassium that's contained in the endolymph. As the potassium crosses throughout the endolymphatic spaces in that area. The next potential is, the next three are what we refer to as action potential, because there needs to be a stimulus in order for the action to occur. So the first potential that we can measure is called the cochlear microphonic. The cochlear microphonic is a potential that's generally comes from the outer hair cells, and it mimics the input of the stimulus. After the cochlear microphonic is the summating potential, also referred to as the SP, and the summating potential is the sum of hair cells, both the inner and outer hair cells, as they move in response to the basilar membrane movement. So if you remember, the basilar membrane is the floor of the cochlear duct, and the organ of Corti sits on the basilar membrane. The organ of Corti is made up of inner and outer hair cells, as well as some supporting cells. So the summating potential is all of those hair cells moving when the basilar membrane moves. And then finally, the action potential, sometimes referred to as the whole nerve action potential, but we can just call it the AP, is the sum of synchronous firing of nerve fibers that are innervating the inner and outer hair cells. So auditory evoked potentials reflect the electrophysiologic function of a certain portion of the central auditory nervous system in response to sound. So it's electro, meaning that the responses are collected by electrodes, and physiologic, meaning it's the physiologic function of the system, so it's not something that anybody can control. These measurements, these evoked potentials, are measured. The measurements are a result of the changes in the ongoing brain wave called an EEG, which is the result of the synchronous firing of neural units. Okay, so this is what an EEG or electroencephalogram is. Generally, an electroencephalogram is measured using a whole bunch of electrodes placed all over the head. There are two different ways that you can measure this. With the electrodes that are placed all over the head, and there's like paste everywhere to make sure that you get a good seal on the skin between the electrode and the skin, or a newer way to use it is this cap that has the electrodes on there. Either way, these electrodes are bundled together and they go into a box which measures the ongoing activity of the brain waves. And this is the box right here. And then those ongoing wave activities are converted to a computer signal that allows us to look at that ongoing brain wave. So first up is the electrocochleography, which is typically recognized by its acronym ECOG or ECOG. Sometimes you'll see ECOG. Either are acceptable. And this measure is kind of outdated, although it is used frequently for some differential diagnosis. So an ECOG is used to evaluate the electrical potentials in the inner ear and the auditory nerve. There are two major reasons why we use ECOG clinically. The first is to detect elevated pressure in the inner ear. That elevated pressure is referred to as endolymphatic high drops. And so what happens in endolymphatic high drops is there's too much pressure. There's too much buildup of endolymph in the cochlear duct. And so when we evaluate, we're able to measure that overproduction. So that's really the clinical use that most audiologists use. Some audiologists use it during intraoperative monitoring to monitor the auditory nerve function during any kind of brain surgery near or around the eighth cranial nerve. The ECOG measures the relationship between the two cochlear potentials, the summating potential and the action potential, which you'll see here with their acronym. And here's the summating potential and the action potential here. The one on the left shows the relationship as it should be normally. Okay, so there should be a great gap between the summating potential and the action potential. When there's not a large gap between the two, it often indicates endolymphatic high drops, is considered abnormal, and is often a sign of Meniere's disease. Okay, we're going to watch a quick video here. Okay, in the video, he mentioned 3 different types of electrodes. And so those 3 different types of electrodes are in the ear canal, up against the tympanic membrane, and through the tympanic membrane. An audiologist in practice by themselves can do the first 2, but in order to do a transtympanic, it involves sticking a needle with an electrode through the TM to the back of the middle ear next to the cochlea. That results in better waveforms, but we can use the other 2 types just as well. You just have to program your computer for the right type of electrode. Okay, so this is the 2 recordings of the differential diagnosis for Meniere's disease. And, excuse me, we always do a 2 trial run. In order for the results to be accurate, we have to have a certain degree of repeatability. Okay, so that's a key in many electrophysiologic measures, is that we have to have a repeatability. And so the first trial, or the first run, is in the light blue, and the second one is in the darker blue. And you'll notice that the waveforms look pretty similar to each other, and so they are considered to be repeatable. The next thing that we want to look at in this is the difference in the summating potential versus the action potential. Okay, so the farther the farther these 2 are apart, the better. Okay, so here we can see there's the summating potential here and the action potential here. So the right ear is normal, or doesn't show endolymphatic hydrops. But over on the left ear, you'll see that the summating potential and the action potential are very close together. So the closer they are together, the more likely we are to see endolymphatic hydrops, which is indicative of Meniere's disease. These are not tests that speech-language pathologists would use, but know that if you have a patient that you're working with who has Meniere's disease, they can't be officially diagnosed with Meniere's disease unless they've had this test. This is the only test that is used for the differential diagnosis of Meniere's disease. Otherwise, we can only speculate, but we can't say for sure whether a person has Meniere's disease. Okay. Next up is the evoked potentials, specifically auditory evoked potentials. And the ABR is also an early response, and typically the equipment that we use, let me just say this. There are multiple names for these auditory brainstem evoked potentials. The 2 that you see most common are BAER, which stands for brainstem auditory evoked response. But the most common is ABR, which is auditory brainstem response. And again, the auditory brainstem response is an early onset measure. Okay, so the equipment is kind of similar to the Ecog. We have a computer that monitors the ongoing EEG, and so we have electrodes that are here, and those electrodes plug into this monitor here. And this monitor evaluates the ongoing EEG as we add stimulus in there. And the stimulus that we typically use is insert earphones, which this is an insert earphone. You'll notice up here that we can also measure bone conduction, ABR. And sometimes in the differential diagnosis for ABR, we can look at the differences that are obtained using insert earphones to see if there's an air bone gap or not, to determine if it's sensory neural or conductive hearing loss. We cannot tell mixed hearing loss. It will only show up as sensory neural or conductive when using an ABR. All of this data, then the ongoing EEG as well as the stimulus introduction, is dumped into a computer, and then the computer gives a graph of the ABR, and the graph is what an audiologist or maybe an otologist will evaluate to determine what's going on. Generally, when we do these recordings, we ask, and this is the same for Ecog as it is for ABR, especially with adults, we ask the patient to relax or take a nap. Sometimes when we do it with kids, we have the parents make sure that they're sleep deprived so that they'll possibly sleep while we're doing this test. So why do we use ABR in clinical settings? Well, the use of ABR is much more widespread than the Ecog, and it's been implicated in a bunch of different ways. The first one is in newborn hearing screenings. Last week we talked about the Universal Newborn Hearing Screening initiative that is required in every state and how OAEs are typically used for that. But another use for an ABR is to do a newborn hearing screening. So it would be a screening ABR, and the disadvantage of the screening ABR versus an OAE is it only takes a couple of seconds to do an OAE, where it takes 5 to 6 minutes per ear to do an ABR. Sometimes we can get that down to three minutes, but we're still looking at a significant time difference. But it's actually more sensitive to hearing loss than an otoacoustic emission. So some hospitals will use a combo OAE ABR screening. So if a baby fails the OAE, they will do the ABR right away after that. And also the ABR is a little more sensitive to noise, like if the baby is moving around. So those are some of the reasons why we don't always use ABR in the universal newborn hearing screening. The second is for threshold estimations. So for threshold estimations, this is often the second step in the universal newborn hearing screening of an infant who has not passed their newborn hearing screening. So it lets us know what the threshold estimations are for an infant or a young baby. Another thing that ABR can do is help to determine the type and the severity of the loss. The type is done, and sometimes this has to be done over several days or a couple of weeks, but the type, remember, is conductive, mixed, or sensory neural. So we can evaluate conductive versus sensory neural by doing an air conduction ABR and a bone conduction ABR. And it also helps us determine the severity of the loss. Is it a mild, moderate, severe hearing loss. So the ABR is able to do that. An otoacoustic emission cannot, with any degree of certainty, determine the type of loss. And it really is only good at detecting hearing loss up to a moderate. Another thing that ABR is used for is the detection of lesions along the auditory nerve and in the brainstem. So if a person has a tumor or a demyelinating disease, we can detect this using the ABR. The preferred measure of interoperative monitoring is through the brainstem auditory evoked potential, or the BAER, although some people use ABR. So ABR, just like Ecog, can be used in interoperative monitoring while individuals are having brain surgery. And finally, the ABR was instrumental in the development of cochlear implants to determine if there was synchronous firing of auditory nerve fibers. Okay. When we run an ABR with our equipment, we're looking at waves, and these waves are what helps us differentiate the different types of diagnoses that happen. So wave 1 in an ABR is the same thing as the action potential in the Ecog. And it's generated from the synchronous firing of nerve fibers. Wave 3 and 2 and 3 is a kind of a wave complex, are generated by the cochlear nucleus. Sometimes the superior alveolar complex is implicated in that, which is the first stage of, or the first area in the central auditory nervous system of crossover. And then we have the wave 4-5 complex, which comes from the lateral lemniscus. This is just a representation of our wave 1, our wave 2, our wave 3, and our 4-5. Okay, so the 1, 3, and 5 are typically the ones that are used to determine issues or problems with the ABR. So when we diagnose, we look at those 3 waves, and the waves are reported in terms of their latency, or what time they occurred after the stimulus. And it's typically in milliseconds, so this is a very quick onset. So the latencies are measured of wave 1, wave 3, and wave 5. We can look at absolute latencies, so the latency of each of those 1, 3, 5, or the interwave latencies, which is how much time between 1 and 3, 3 and 5, and 1 through 5. Okay, and then they're compared to norms. And we have norms for both absolute and interwave latencies. Okay, so here is, this is 2 different data tables. And over here, you'll see that the intensity, there's 90, 70, 50, 90, 70, 50, 30. So these are the expected onsets of each of those waves at 90 decibels, at 70 decibels, at 50 for wave 1. Generally, wave 1 disappears around 50 decibels, so we can't really look at it. But you'll notice that the softer the intensity, or the lower the intensity, the greater the time it takes for us to observe the waveform. So at the intensity of 90 decibels, the general adult population, we would expect to see wave 1 at 1.49 milliseconds. So each of these is measured in milliseconds. Okay. When we lower the intensity to 70, it extends what time the wave occurs. And you can see that it steadily increases as the intensity decreases. Okay, so the latency is going to increase as intensity decreases. Okay, so for neurological purposes, we're always using the 90 decibel. So we would look at wave 1, wave 3, and wave 5 at 90 decibels. Okay, so we're looking at 1.49, 3.73, and 5.53. Those are the times that they should occur. If they occur outside of that, it's abnormal. Okay. Another study looked at the difference between men and women. And you'll notice that men's occur at a little sooner time than women. So this study teased out male and female. This study that established norms is everybody in general. Then we can look at the latencies for infants. Okay, so for infants, their latencies occur a little bit later. Each number along here represents the age in weeks. So this is 35 weeks, 40 weeks. Okay, so really, for the first 200 weeks of a child's life, their latency for wave 1 is a little bit longer. So it occurs at a little bit longer. Okay, 1.6, 4.37, and 6.75. Okay, so a standard deviation is before and after that can be up to, so normal would be 1.83 to 1.37. So anything in there would be normal. Okay, so we expect that younger kids have longer latency, so it occurs a little bit later. Okay, and somewhere, so 200 weeks is about just under 5. Okay, the responses of the central auditory nervous system kind of start to become adult-like around age 6. Okay, so we do expect that there's a difference, especially for infants and young children compared to adults, which is why we have 2 different sets of norms. Okay, so ABR for neurology can evaluate whether there's a tumor along the 8th cranial nerve. And it can also identify demyelinating processes like multiple sclerosis and ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease. Okay, so we can see changes in the ABR for neurology early, sometimes before a person may even be experiencing symptoms of the disease. We see abnormalities in the ABR when we're using the neurology protocol. for auditory sensitivity. As we decrease the intensity, we saw that on the norms for adults. We see that the latencies increase, but they should still stay there. Okay, so we should still see the waves. Except for wave 1, we should still see 3 and 5 below 50. So the absolute latencies, the time that each of those waves occurs, increases, but the interwave latencies stay the same. And just like with Ecog, the morphology, so the morphology is what the waves look like. Do the waveforms look good? A waveform should look pretty clean and not with a lot of noise or jagged peaks. They should be smooth peaks. So jagged peaks mean there's too much noise or you don't have a good skin to electrode contact, which you should always check before that wave starts. And then the repeatability. So you should always have 2 trials, minimally 2. Sometimes we do 5. And if we're doing for auditory sensitivity, we do a whole lot. So we do 2 runs at 90, 2 runs at 70, 2 runs at 50, 2 runs at 30. So every time you decrease the intensity, then you have to check for repeatability. If you can't repeat the results, they're not considered valid. Okay, and that wraps up ABR.